Today we will discuss something about the disease, that is valvular heart disease. Today we are having here experts from Escorts Heart Hospital, and I am very happy to introduce Dr. Ravi Kasliwal. He is program director in DNB Cardiology, and he is also a program in charge of Escorts Heart Hospital of the PGDCC program. Next to him, in the middle, Dr. Manish Bansal. He is also one of the academic counselors of the PGDCC program. And just next to me, she is Dr. Sini, and she is also one of the academic counselors of the PGDCC program. So I would like to request Dr. Ravi Kasliwal, please sir, start the topic.
Before we start echocardiographic assessment of valvular heart disease, be very clear about a few things. That you will have by then taken a detailed history of the patient, you will have clinically examined the patient, you would have an ECG of the patient, an X-ray chest of the individual, and hemoglobin. Without these prerequisites, don't take hold of the transducer and jab it on the patient's chest. The reason is all these things give you a detailed information about what you are looking at, what the valve will be like, and what you anticipate. So don't just think that when we talk of echocardiographic assessment of valvular disease, the first thing we will do is to put the transducer on the patient's chest. We have to know, it has to be goal oriented. You have to know what you are looking at. And having said that, of course, there will be surprises, which you will take it in your stride. But however, you must know why you are doing the examination. It's extremely important. Why is hemoglobin so important? Because many times some disease processes give rise to anemia, like infective endocarditis. Or sometimes anemia makes a murmur more prominent, and you may not find such a regurgitant lesion in actual practice. An extra chest, ECG, a good clinical examination, following a good history taking, will give you a very good assessment as to what you are expecting, and then you go ahead and put the transducer on the patient's chest. It tells us about the presence of disease. What does that mean? You can confirm your diagnosis. So first is, what is the diagnosis? So it will tell you the presence of the disease. Secondly, it will tell you the etiology. If it's a bicuspid aortic valve in a young individual, you know that this could be as a result of a congenital disease. If there is a flagellar mass attached to one of the valve leaflets, then you know this may be because of infective endocarditis. Associated anomalies are also extremely important. Why? Because along with mitral stenosis, sometimes there may be a loud mid-diastolic rumbling murmur with a pre-systolic accentuation. In that milli, you may have missed an early decrescent to diastolic murmur of aortic regurgitation. It will tell you about other valves. It will tell you about chamber sizes, how big is the left atrium, how big is the left ventricle in aortic regurgitation. Very importantly, it will tell you if there is left ventricular dysfunction or not. As my colleagues will tell you, when you are dealing with a case of aortic stenosis, for example, if the LV function is on the lower side, if there is LV dysfunction, the complete gradients that you have got will be fallacious, and you will have to interpret it in the light of the LV function. So that's again extremely important. And then, of course, having said that, you will be able to find out the severity of the lesion. So not only you will find the presence of the disease, the diagnosis of the patient, you will also know the severity of the lesion or the lesions. And one thing which then comes from there, what route do you take this patient? Is it medical follow-up? Do you give more medication? Do you do intervention, or do you take up for surgery? If you are taking this patient up for surgery, echocardiography will tell you which kind of surgery. So from an investigation which was 20 years ago an ancillary procedure, now echocardiography in valvular heart disease is a definitive procedure. No surgeon will ever touch a patient of mitral valve disease until and unless he has gone through extensively transthoracic, transesophageal and 3D pictures to find out what will he do with this patient. Will he repair it? Will he replace it? And if he replaces it, what size of prosthesis he will require? All these are important questions when you're dealing with valvular heart disease. Mitral stenosis, rheumatic heart disease, is the common etiology, 99%. Other rare causes are congenital carcinoid radiation, calcification of mitral annulus, or methotrexate therapy, or SLE. But remember, mitral stenosis is rheumatic heart disease. Once you are looking at the patient, there is a history of shortness of breath, even PND. The X-ray shows pulmonary arterial hypertension, pulmonary venous hypertension. The ECG shows a left atrial enlargement, a normal sinus rhythm. Then you have placed the transducer in the parasternal long axis view. Now you can see very clearly here that you are seeing the anterior septum, as we discussed last time. You are seeing the aortic root, and you are also seeing the aortic valve fluttering inside. Below the aortic root, behind it in fact, you are seeing a chamber which you know is the left atrium, and it appears enlarged to you because even roughly you know that this is the aortic root. It seems larger than the aortic root, and you are seeing two mitral valve leaflets. You are seeing the anterior mitral leaflet, and you are seeing the posterior mitral leaflet. You are seeing that the leaflets are thickened. Doming of the anterior mitral leaflet, mind you, this is an important characteristic, an important criteria of mitral valve stenosis. Doming, it domes. In this particular case, the posterior leaflet is relatively fixed. It is moving some, but you can see that it is fixed. At least in this view, you are seeing no real specks of calcification or even calcific masses. So this appears at this point. And of course, you can look at subvalvular pathology. Now, if you would turn on the color gain, you would be able to see if there is any associated aortic regurgitation or mitral regurgitation. However, at this point, just concentrate on the fact that this is parasternal long axis view showing an enlarged left atrium and thickened non-calcific mitral leaflets with a fixed PML and a domed anterior mitral leaflet. And this is the left ventricle here, and that's the right ventricle here. And now we are in the apical four-chamber position. When you are looking at a patient of a stenotic lesion, be it MS or AS or PS or TS, two or three things are common. You will want to know the gradient across the valve, the area of the valve. In these two measures, echocardiography stands alone. There is nothing which can give you these two measures within 20 minutes of the application of a transducer on the patient's chest in the left lateral position. You will know the entire sequence of events. You will know the entire diagnosis. From the parasternal long axis view, you have gone straight to the, let us say, you have gone straight to the four-chamber view. And what do you see here? Left atrium. That's the left ventricle here, very clearly. And I'll show you the color phenomena taking place here. Below the left ventricle is the left atrium. And you know, you have taken the dimension. It is enlarged left ventricle. As the blood is entering from the LA to the LV, you find a jet, and I'll explain about this. But at least you are seeing no jets in systole back into the LA. So at least you are clear that you are dealing with predominantly mitral stenosis. And of course, we'll take this in several other views. Why should we do color Doppler? We can just put a continuous wave Doppler here and we'll get the gradient. Well, the color Doppler helps you in several ways. For aligning your continuous wave Doppler beam, it is extremely important. Otherwise, you may align the beam here or align the beam here, and yet you will not know that this is the true gradient or not. So this is the valve here, and from the valve, the red blood cells come from the LA to the LV. Because the valve is stenosed, this is not a laminar flow, right? If ever there is an example of turbulent flow, this is turbulent flow. Once you have seen it, you can never forget it, right? So this is coming from a tight, stenosed valve. It has to flow from the LA to the LV, and this is mitral stenotic flow. When we then place a continuous wave beam, we keep it parallel to it, we will get the gradient, and I will come to that. Now, why are we saying again and again that we should position a continuous wave Doppler? Why? You know it. Last time we discussed that continuous wave Doppler it will give you higher velocities, and you know this is a high flow situation. So therefore you will use a continuous wave Doppler. So pressure gradient. So now we are going into one of those things which defines echocardiography above any other investigation. No X-ray investigation will ever give you a gradient, will ever give you a valve size. Here you are saying the actual hemodynamics as it occurs. You increase the heart rate, gradient will change. You decrease the heart rate, gradients will change, but the valve area will not change. So truly, many laboratories around the world, they don't call their laboratories as echocardiographic laboratories, but they call themselves as hemodynamic laboratories. Why? Because you're giving hemodynamic information. Let us see what a normal mitral valve inflow looks like. You know this. However, when I will show you, when we'll see the pressure gradient across in a mitral valve, you will see how big the difference is. And your eyes will then pick it up very nicely. Now you see, this is the E wave and that's the A wave. This is done by a pulsed wave Doppler, and the pulsed wave Doppler is positioned at the tips of the mitral leaflets. So the blood is coming from the LA to the LV, and you are inscribing the E wave. You know the E wave takes place during the first onrush of blood when the mitral valve opens from the LA to the LV. Mind you, all this is occurring in diastole. Be very clear, this is diastolic parameters. Once the blood flow has come in, then there is a phase of diastasis in which the left ventricular pressure is rising. The mitral valve leaflets have floated back to their closed, not to the fully closed position, but at least to some extent, and there is very little blood flowing there. This is the phase of diastasis. And then when the left atrium starts contracting, you will find another 15% of blood, 10% of blood flowing from the LA to the LV. So this is the inscription of the A wave here. You have the E wave here, and in between there is diastasis. Now, because this person doesn't have mitral regurgitation, he has no other lesion, therefore the systole is relatively quiet. You find nothing here. And when you know what a normal looks like, then you will appreciate very clear. It exactly depicts the hemodynamics of the blood flow from the LA to the LV. The first onrush of blood, the diastasis, and the A wave. Now you can very well imagine if the patient gets atrial fibrillation, then you're going to lose that A wave, right? Because now the atria are not contracting in a synchronized fashion. What will happen to the patient? Patient with atrial fibrillation and mitral stenosis might come to you immediately with palpitation, but more importantly with signs of congestion, because now his LA is not empty. He gets back pressure, he gets pulmonary venous congestion. It's very common to find young patients who till yesterday were doing relatively well. 1 hour, the A wave is knocked off and they're down in left atrial decompensation, right? So that's the importance of the A wave here. Having seen the normal, having seen that we have got this tracing, having taken the color gain, having put the color Doppler on, and we have put very parallel to the color Doppler, we have positioned the continuous wave Doppler beam across the mitral valve, and then look at the E and A wave. They've disappeared literally, isn't it? There is no diastasis. It's so high. This is severe mitral stenosis. And as contrast to this is mild mitral stenosis, because if you look at, this is the E point and the pressure gradient equalizes in no time at all. Here it is not equalizing even at the end of A wave, and you find such a large gradient across the mitral valve. Remember, this gradient is at the mitral valve level. So if you are doing a catheterization, you will have to retrogradely put one catheter into the LA and then put one catheter into the LV, and only then you will get it. Today nobody does it. It's not required. Why? Because echocardiography has taken over all this gamut, because within 10 minutes you can find out what's going on with the patient. So pressure gradient, this is of course dependent upon heart rate and cardiac output? Sure it is. But the idea here was to show you the difference between mild mitral stenosis, severe mitral stenosis. And this is the ACC-AHA 2006 guidelines for management of valvular heart disease. And this is important from examination point of view, from patient point of view, from follow-up point of view. Mind you, echocardiography is one of those investigations which is used on a day-to-day basis for follow-up of patient, because the first time the patient comes to you, his main pressure may be less than 5, he is mild. So leave him alone, just give him penicillin injections, or whatever else, digoxin, whatever he requires. The minute from mild he becomes moderate, you have to start thinking. So what is the criteria? Internationally accepted parameters are mean gradients, valve area, and pulmonary artery systolic pressure. Now we divide this into mild, moderate, severe. Mild meaning mild mitral stenosis, moderate stenosis, severe stenosis. If the mean pressure gradient, P stands for pressure here, mean pressure gradient in millimeters of mercury is less than 5, when a patient is lying supine comfortably with a valve area of 1.5 centimeters square and with a PA systolic pressure of less than 30 millimeters of mercury, the patient is classified as mild mitral stenosis. He gets into the moderate range when the mean pressure is above 5 but less than 10. The valve area ranges between 1 to 1.5 and the PASP is more than 30 but less than 5. Done the echocardiography of this patient, who very likely may be a young girl, or follow-up. Naturally the parents will ask you, okay, sir, what do we do with the child now? And you say, all right, the patient has mild mitral stenosis, we will continue medical follow-up. Now when he goes into the severe phase, where the mean PG is above 10 millimeters of mercury, mean pressure gradient, the valve area is less than 1, the PASP is more than 50, that's the time when we will say, okay, let us open this valve. Of course, you can start thinking even between moderate, while the patient has moderate severe disease, but certainly if the patient has severe mitral stenosis, no other lesion, no regurgitation, then that's where you will start considering intervention. So mind you, echocardiography therefore has helped you in so many ways. First, it confirmed your diagnosis, because a mid-diastolic rumbling murmur with a pre-systolic accentuation, a loud forced sound, you saw an opening snap, it told you yes, the anterior mitral valve is domed, it is pliable, and we'll come to this, it has helped you. So severity of mitral stenosis, it's very, very important that we know the guidelines so that there is no ambiguity. So that when you talk to your cousin in New York City and when you say this patient has a grade of so and so, she understands it's moderate. Nothing has to be done or something has to be done. So we are talking international language. Don't make it up. This is well defined. Echocardiographic estimation of mitral valve area can also be done. It's not only gradient. We can find out by planimetry directly, by continuity equation, by PISA, or indirectly by pressure half-time method. And here I will talk to you about planimetry and pressure half-time. Planimetry is an accurate method. I won't say most accurate, but it's an accurate methodology for estimation of mitral valve area. Now the bottom line here is when performed by an experienced echocardiographer. That's important, because if you have cut the mitral valve at a tangential angle, you will get an abnormal report. It has to be at the tips. It has to be well defined. Only then will you freeze frame it and planimeter it, and we'll show you how. Advantage, the valve area is not affected by hemodynamics. Whether the patient has an associated AR or he has an AS, it doesn't matter. Your valve area will be valve area. Now limitations, these are not limitations, but they are just the caveats to it, that you need to have good image quality, that you must do the measurement at leaflet tips only, and this may underestimate mitral stenosis in only one condition, that the mitral stenosis predominantly is as a result of obstruction at the subvalvular level, right? The mitral stenosis can be valvular, with the commissures, and it can be subvalvular, and I'll show you what subvalvular I mean. Alright, having said that, planimetry is a good methodology of assessing directly the valve area and saying, look, this is now less than 1 centimeter square and something needs to be done. How nicely you are seeing the valve area. The commissures are free of any calcification, and you are seeing the opening. So at the time when it opens maximally, you freeze frame it, and then with your cursor you can draw, you can planimeter it like this, and on the screen you will get an idea of exactly how many centimeters the valve leaflet is. So this is mitral valve area planimetry.
One thing is, when you call a leaflet thick, I think we should all know that in case we are getting confused that whether the valve leaflet is thickened or not, then you can measure it in diastole, and the thickness should be more than 4 millimeters, and then you know it's the leaflet is thickened. And Manish, would you like to add?
Yes, that's a very good point. When I mentioned thickness, I should have mentioned that. But what is thickening after all? It is thickened vis-a-vis something which is normal. So if it is more than 4 millimeter, and you can easily do it. See, the beauty of the instrumentation is that you don't have to do it with your ruler, with a scale. The scale is inbuilt into the machine, very, very effectively, and you can exactly say, okay, this is 4 millimeters or less. Dr. Bansal, would you like to say something?
Yes, somebody had raised the question last time how to obtain an image for planimetry. So we had discussed this last time also, that for doing planimetry, first make a good flex view, then bring the mitral valve leaflet tips in the center of the image, then rotate the probe by 90 degrees so that the mitral valve leaflet tips come in the center, and then go towards apex of LV, and from there try to gradually come towards LV base. So the first point where we are able to see the orifice clearly is the point where we have to measure the area. So that is how we do we planimeter the mitral valve, because
I just wanted to add another thing. When do we call that there is mitral stenosis? We've seen the normal valve today, we've seen the abnormal valve today. A normal mitral valve should not have any gradients, but gradient of 2.5, if we are tracing doing a CW and tracing the CW trace, and if the gradient is more than 2.5, then you call it mitral stenosis. And the normal mitral valve size is 4 to 6, but when it comes to 2.5 centimeters square, that's the time when we call it a stenotic valve. More than 2.5, the valve we tolerate it. We don't call it a stenotic valve, but from 1.5 to 2.5 is the mild mitral stenosis. So you start calling a valve stenotic when the gradients are more than 2.5, and 2.5 to 5 it is mild mitral stenosis, then 5 to 10 we've studied it is moderate mitral stenosis, and more than 10 mean PG is severe mitral stenosis. And another important thing is in patients who have a controlled heart rate, the gradients could be low even with severe mitral stenosis. Like if the patient has a heart rate of 55, patient has been given either beta blockers or is on digoxin, and you have on 2D examination you feel that the stenosis is pretty tight and the gradient you're getting is about 7 or 6, then you have to rely on planimetry. So that's the importance of planimetry. You have to totally rely on planimetry in those particular cases when the stenosis is there, but due to the controlled heart rate you're not able to get adequate gradients.
Means the diastolic filling period is
similarly in atrial fibrillation with fast heart rate, gradient will be falsely high. MS may not be that severe, but gradient may be much higher than the severity as seen on planimetry. So planimetry becomes more reliable in these situations.
Actually, these are very important points. See, that's why when we started, I said clinical examination, clinical setting is extremely important. Now, my colleagues have pointed out two very, very important points. That look, if the patient has got digoxin toxicity, for example, and the heart rate has come down to 45, 50, and he comes to you with whatever complaints, and then you do an echo, you will find that the diastolic filling period is so large that the pressure gradient may fall into 0, and yet the patient may be having a severe mitral stenosis. So you have to see gradient in a certain way. You have to understand it, that if the diastolic filling period is more, then it's going to be a different situation. That's where here in such a situation a valve area will help. Don't be in a rush to do the first valve area and say this is the valve area. No, as Dr. Manish is saying, it's extremely important to have a good image. Put the patient in a left lateral position. See that the patient is at ease, is not tachycardic. Then you make a good image, planimeter it, and you will get a valve area. See, one of the things which people tell about echocardiography is that they say, oh no, it's too operator dependent. Well, if the operator is well trained, if the operator knows what he wants to show, then two good operators will come across the same valve area, whatever you may do. But this is one of the things which people who are not used to echocardiography always level this against echocardiographers. Oh, this investigation is too operator dependent. Well, everything in life is operator dependent for that matter. So, planimetry, as my colleague has said, is a very important point. Once you have tachycardia or bradycardia, or you have done balloon mitral valvotomy, at that time only planimetry will tell you what is the valve area, correct valve area of the patient. Pressure half time. This is another methodology of defining mitral valve area. One is directly doing it on a short axis view at the tips of the mitral leaflets. It's an actual tracing, but this is derived, pressure half time. Let me tell you a little history here, that the pressure half time method was defined by a lady called Liv Hatley from Sweden, and she now works as an emeritus professor in the Mayo Clinic, Liv Hatley, and her engineering colleague, one person called Mr. Bjorn Engelson. They wrote a book actually on clinical echocardiography, and this was a paper published in 1978 in the British Heart Journal. They first defined what is pressure half time, and this is the time required for the pressure gradient across the valve to fall from peak value to half of this value. And this, by a formula 220 upon PhD, gives you a mitral valve area. Alright, this is peculiar to mitral valve, that this is, and this has been done extensively by studies by the engineers. And so you can find out. Now if you look at this patient here, there are two pressure tracings. Tracing on top is mild mitral stenosis. This is the left ventricular trace. This is the left atrial trace. In diastole there is a gradient Pmax by half. This is the time it takes to fall to half of its peak value, right? If you look at this pointer, from the peak value to half the value, this is T half, and that is what pressure half time relies upon. Similarly, if you see it in the mitral Doppler analysis, this is the max, this is the half, and this is the T half, right? And then you apply this to a formula and you will get the mitral valve area. Now if the patient's heart rate is not very high and is comfortable, you'll easily be able to make out between mild mitral stenosis and look at the tracing below, that is severe mitral stenosis. As you can see in the CAT study also, there is a large gradient between the LA and the LV. In real life, of course, you won't get LA tracing, it will be the pulmonary capillary wedge tracing, which is an almost true reflection of the LA tracing, but you see the gradient, how nicely you will see, and similarly the echo echoes it beautifully. You will see the pressure half time, the T half has now increased, and when the T half is increased, it has got an inverse relationship to the mitral valve area, and so you will get a smaller mitral valve area. So there are methods, cross checks and cross checks, that you can directly see the valve area. You can also do it by the pressure half time method. This is the normal value or the pressure half time, and this is pressure half time in a patient who has severe mitral stenosis. Now you have to keep the first dot at the peak of the E wave and then draw out a curve. You can't place it here or here, it has to be here. So let me remind you, we have the patients, the patient in the left, we have the transducer in the apical 4-chamber position. This is the domed mitral leaflet. We have positioned the continuous wave Doppler beam across the mitral valve, absolutely parallel, and this is the gradient that we have got. This is the E wave here, and we have positioned the cursor right at this point. Then when we leave it to the computer, it gives us a Vmax of 221 centimeters per second, a pressure half time of 183 meters per second. So the mitral valve area is 1.2, right? This is not deep mathematics. This is the computer will give you, don't worry. But if you have positioned it here and then you take the beam up to this point, then as you will see in the lower part, the Vmax will be only 173, the pressure half time will be only 149, and you will get a valve area falsely of 1.48. So it's almost 1.5 centimeters. So see, this is why people say it is operator dependent. I mean, if you have positioned the beam, not taking the beam correctly, if you haven't positioned the patient correctly, you'll get all false values. But if you have done it 1,000 times, you will never miss it, right? So this is pressure half time mitral valve area, and the last one was direct planimetry of the valve area. Advantages: PhD is not altered by cardiac output, that's important, or mitral regurgitation, or the duration of the diastole, right? Just as the gradients are, the gradient will be affected if there is diastolic duration is long, or if there is a decreased cardiac output, then the gradients will be falsely low. All right. Of course, there are limitations, that if there is coexisting aortic regurgitation or hypertension, anything that, or severe aortic stenosis, or immediately after balloon mitral valvotomy, because the compliance of the left ventricle is altered. Once the diastolic compliance of the left ventricle is altered, obviously you will find a problem in pressure half time. So from PhD we move to continuity equation. Continuity equation is not very much used for the identification of mitral stenosis or a mitral valve area, except if the patient has, except in the absence of significant MR or AR or VSD, then you can apply this formula: mitral flow is equal to left ventricular outflow tract flow, and you will get a mitral valve area. Now, generally, the continuity equation is used for other things, as my colleagues will tell you, but mitral valve area, you just need to know that, all right, I can calculate the area by pressure half time, I can calculate the mitral valve area by directly planimetry, and yes, continuity equation can be used. Now, a couple of important points. We have said a lot of things. Mitral stenosis is the commonest mitral condition, and your colleague will ask you that, look, can I do a mitral valvotomy on this patient? Can I do a BMV? Very important to visualize mitral valve in short axis for commissures, because presence of calcium in the commissures makes the valve not very suitable for BMV. These are the commissures here, this one and this one. You see it here and here. So it's very important, it's very important that we talk about commissures. We talk of calcium. If both the leaflets are heavily calcified, and you will see that because calcium in the valve leaflets will give rise to acoustic shadowing, and when there is acoustic shadowing, you know that these valves, once the balloon goes in and you inflate the balloon, there are likely chances of creating a mitral incompetence or even valve rupture. So those may be. So as I started this discussion with you, that not only you will be able to know by echocardiography the diagnosis, but you will know the timing and the type of intervention. So these two T's are important: timing and the type. Subvalvular apparatus is again one of those things. It's very important to assess it, because if subvalvular apparatus is very thickened, then of course you might like to take this patient some other route than a balloon mitral valve. Now, is there a score for valve morphology? Yes, there is a score. It's the Wilkinson score, and it's tragic that we in India haven't come out with a score because it's so common in our country. But it's the most commonly used scoring system. Parameters assessed are leaflet mobility, leaflet thickening, leaflet calcification, and the state of subvalvular apparatus. Now that you have been with us for the last 40 minutes, you can talk about, you know what I'm talking when I say valve mobility, you know about thickening, you know about calcification, particularly commissural calcification, and you know the state of subvalvular apparatus. Each parameter assigned has a score of 1 to 4, where 1 means very good and 4 means bad. So any valve in which the score is less than 8, that means Valvular mobility, very good. 1. Leaflet thickening, minimal, say 2. No calcification, state of subvalvular plus. You get a score of 4. Great valve for balloon mitral valvotomy. Mind you, this is incomplete till you do a transesophageal echo and demonstrate some other things which I'll come to. But you must know Wilkinson's name. You must know that he made a score. You must know that these are 4 important points. Mobility, thickening, calcification, subvalvular, Wilkinson score. I will not go into the details of it. You can get it from anywhere. Let's say grade 1, when you talk of mobility, mobile valve. Grade 2, mid and basal portions have normal mobility. Valve continues to move forward in diastole, mainly from the base, for no or minimal forward movement of the leaflet. And this is how it goes. Subvalvular thickening of the leaflets, and calcification. If there is a single area of increased echo brightness, don't worry. You can still send the patient for a VMV. So these are things which you need to know, you need to look at. But once you have done 100 patients with mitral stenosis, keeping this in mind, you will be able to tell your interventional colleague whether he can or he cannot go ahead with the balloon mitral valvotomy. And this is what we do in our institution. This is a 3-dimensional echo of a mitral valve. I'm not going to go into details of 3-dimensional echo except in saying that this is the future. The future is here. If you look at the mitral valve taking away the left atrium, then you are actually peering down at the mitral leaflets. And when you take away the left ventricle, then you are looking up towards the mitral valve. You will get to know about the subvalvular pathology. And then you can rotate the heart any which way you want and make up suitability or otherwise for balloon mitral valvotomy. This is one of the first pictures ever taken in cardiology wherein you have a balloon actually across the mitral valve being inflated. This is actual 3D picture, and this is post balloon mitral valvotomy. See how beautifully it has been opened up post BMV. 51 years ago, MS was diagnosed by reduced EF slope, thickened mitral leaflets, paradoxical motion of PML, and that's what you see here very nicely. And this is the history of echocardiography. You want to know, don't want to give her a scar on the chest, you want to take her for a BMV, you need to know associated mitral incompetence. You need to know about other valves, and sometimes, at least like in our own institution, no patient will go for balloon mitral valvotomy until and unless we have done a transesophageal echocardiography, because only TEE will reveal LA and LAA clot. The specificity and sensitivity is what? Less than 60% for a intrathoracic echo, and spontaneous echo, what, 2 minutes only? Yes. All right, no problem. Now it's extremely important to find out about pulmonary arterial hypertension. Look at the mitral tricuspid regurgitation, through the tricuspid valve. Now you have put your continuous wave Doppler here, and you can easily find out the PAH, the degree of PAH, and you can also find out whether this tricuspid regurgitation is organic or whether this is functional. This is extremely important because sometimes the pressure TR jet may be large, the PA pressures may be low. That gives you an instant pointer. This may be organic TR. Don't be surprised. TR is a common associated anomaly of mitral valve, and functional and organic TRs are not so uncommon. And of course, the transesophageal echo will give you thickness of the interatrial septum. So transesophageal echo, the aims are to detect clots, severity of MR. Sometimes the mitral regurgitation is a wall-hugging jet which goes just close to the left atrial wall. You may not find it on transthoracic echo, but if you open the valve, this patient is going straight to the theatre. To assess valve morphology better and to assess the state of subvalvular apparatus. There's a large LA clot here. Obviously this negates balloon mitral valvotomy. This is again pliable valve but a large LA clot. This is spontaneous echo contrast. You have to know what is spontaneous echo contrast. This is a clot, but this is a thrombogenic state in which there is ruler formation, and this indicates a high risk for systemic embolization but does not preclude a BMV. And this is some of the studies that we have done, and we'll tell you about spontaneous echo contrast on transesophageal echocardiography. Mind you, this can be present in patients of normal sinus rhythm also, and people with normal sinus rhythm can also embolize. So don't think that it's only AF which causes it.
Thank you very much.